The prostate is geographically divided into strict territories. Where a disease starts inside this landscape dictates how a patient suffers and when they seek care. To understand these diseases, we have to look at the baseline architecture. The normal prostate is built from two components: a network of secretory glands and a surrounding fibromuscular stroma made of smooth muscle and fibrous tissue. These healthy glands maintain a strict bilayered structure. On the outside, a layer of flat basal cells anchors the perimeter. Inside, tall columnar secretory cells line the cavity. This diagram shows the prostate arranged around the proximal urethra. Notice the inner transition zone physically encasing the urethra. Outwardly, the peripheral zone is located superficially along the posterior edge, away from the urinary pathway. These distinct anatomical origins define the patient's symptoms. Benign prostatic hyperplasia almost exclusively originates deep inside the transition zone. Meanwhile, 70 to 80% of carcinomas develop in the superficial peripheral zone. Mastering prostatic pathology requires recognizing this spatial dichotomy. The exact coordinates of cellular proliferation decide whether a patient will experience rapid mechanical obstruction or a malignant growth that progresses entirely in silence. Let's focus on the inner core, the transition zone, where benign prostatic hyperplasia develops. BPH is driven by an excessive, strictly androgen-dependent proliferation of both stromal and glandular elements. Without male hormones, this condition does not occur. As these tissues multiply, they form well-circumscribed nodules. Macroscopically, the prostate expands, swelling from a normal weight of 15 to 30 grams up to a mass of 60 to 100 grams. Microscopically, this expansion looks chaotic, but obeys the rules. Hyperplastic glands maintain their two-layered basal and columnar architecture, crowding the fibromuscular space. Because glands overproduce, they dilate, trapping proteinaceous secretions. This laminated material builds up, forming corpora amylaceae. Trapped in the transition zone, this excess tissue has nowhere to go but inward. The expanding mass physically crushes the urethra, flattening it into a narrow slit, blocking the bladder's exit. The cells themselves are biologically benign, but because they multiply around the primary excretory pathway, it becomes a mechanical obstruction. That mechanical compression translates directly into clinical symptoms, grouped together as lower urinary tract symptoms. Patients experience hesitancy initiating their stream, a noticeably weak urinary flow, sudden bouts of extreme urgency, and multiple nighttime bathroom trips. When the bladder cannot overcome the blockage, urine remains trapped. This incomplete emptying creates a residual fluid reservoir, risking infection. Dangerously, increased pressure forces urine backward up the ureters, dilating the system and causing hydronephrosis, which destroys renal tissue. On board exams, BPH presents predictably. A 65-year-old male arrives at the clinic complaining of progressive difficulty starting his urinary stream and waking up 4 times a night to urinate. When you perform a digital rectal exam, the prostate feels diffusely and symmetrically enlarged. Crucially, the surface is smooth and rubbery, lacking distinct hard nodules. Despite the rapid cellular proliferation and the heavy organ weight, BPH is not a precursor lesion to prostate cancer. The two conditions operate on completely different biological tracks. Every symptom of BPH is a secondary domino effect. The disease itself is completely silent. What the patient feels are the downstream consequences of a lesion trapped inside an anatomical bottleneck. Now we move to the outer perimeter of the gland, the peripheral zone, to examine prostate adenocarcinoma. While early prostate cancer still depends on androgens to grow, it is driven by acquired somatic mutations.
These are precise genetic alterations, like the loss of function in the PTEN tumor suppressor gene, which removes the brakes on cellular proliferation. The most frequent genetic aberration seen in Caucasian populations occurs early in the disease process. The androgen-regulated promoter of the TMPRSS2 gene breaks and incorrectly fuses with ETS transcription factors, creating an active, mutant signaling sequence. As the tumor evolves, it learns to survive therapy. Even if clinicians chemically suppress testosterone levels, the cancer simply amplifies its own androgen receptors, allowing it to maintain growth signaling from negligible hormone levels. Under the microscope, malignant cells look nothing like BPH. The glands are small, crowded together, and they lose their normal folded architecture. Most importantly, they lack the foundational basal cell layer entirely. It is a single, uniform layer of mutated cells.
If you examine the surrounding tissue, you will often find high-grade prostatic intraepithelial neoplasia, or HG-PIN. This is the presumed precursor lesion sitting alongside the invasive carcinoma. Benign hyperplasia merely expands existing, well-ordered structures. Carcinoma dismantles the architectural safeguards, stripping away the outer boundaries to enable unchecked infiltration. To measure exactly how far that architecture has degraded, pathologists use the Gleason grading system. This stratifies tumor aggressiveness based purely on the visual pattern of glandular differentiation. The scale runs from 1 to 5. Grade 1 indicates well-differentiated glands resembling normal tissue. Grade 5 shows no differentiation, appearing as chaotic cell sheets. Pathologists add the primary grade to the secondary grade, yielding a combined Gleason score out of 10 predicting prognosis. Detecting this early is difficult. Because this malignant growth is confined to the outer periphery, it does not press on the urethra. The patient urinates normally, feeling no obstruction. Without mechanical symptoms, clinicians rely on measuring prostate-specific antigen, or PSA, in the blood. But this biomarker has severe limitations. PSA is not cancer-specific. Benign conditions like BPH and simple inflammation cause it to spike. Even worse, 20 to 40% of organ-confined prostate cancers present with completely normal PSA levels that fall below diagnostic cutoffs. Because peripheral tumors grow outward, away from the urethra, they fail to trigger the mechanical alarm bells of urinary blockage. Clinicians are forced to rely on imperfect blood tests and microscopic pattern recognition to catch the disease before it escapes the gland. Once a tumor escapes the prostate capsule, it moves into adjacent soft tissues. Locally advanced cancers will directly infiltrate the seminal vesicles, the wall of the urinary bladder, and occasionally the rectum. When it metastasizes distantly, prostate cancer heavily favors the axial skeleton. It has a highly specific radiological signature. Rather than creating destructive lytic holes in the bone like many other cancers, it produces dense, white osteoblastic lesions, triggering abnormal new bone formation. This pathology gives us two distinct exam vignettes. The early presentation is an asymptomatic 70-year-old male referred after a routine blood test shows elevated PSA. On a digital rectal exam, the clinician palpates an asymmetrical, firm, irregular nodule on the posterior aspect of the gland. The advanced presentation is much darker. An elderly male presents with severe, unexplained lower back pain. Radiographs of his lumbar spine confirm the presence of dense, sclerotic bone lesions. The silent, asymptomatic growth within the peripheral zone has escaped the confines of the prostate gland to colonize the skeleton. The outcome of prostate pathology is determined by its point of origin. Symmetrical inner growth blocks the urethra and signals early, while asymmetrical outer growth remains silent until it invades the bone.